Who has joined us today. We're thrilled that we are continuing our webinars. And I'm Anna Viitala, I'm the clinical specialist at Lymphatouch, and I'm here with the wonderful Hannah Polton, which is, she can present herself soon, but she's a specialist in scars, and she's gonna talk a lot of scars today with us, and this is gonna be recorded, and yeah, it's going to be recorded, and it's going to be a great afternoon here, or night, or morning, depending on where you're from. If you have any questions, please during the presentation, please type it in the chat, and we're going to discuss it end of the webinar, and so on. So yes, let's start with Hannah's webinar. I will share the screen for her because our bit technical issues, but it should be okay. And let's go here. Yes, I think we're ready to go. You're welcome, Hannah.
Thank you. Thank you everyone for attending, and yes, and thank you for your patience while we sorted everything out. My name is Hannah Polton. I own HLP Therapy. Currently I'm the UK leading C-section and scar specialist, and as of February next year in 2024, I'll be embarking on my PhD within caesarean scarring in partnership with lymphatouch. So it's very, very exciting. Next slide, please, Anna. Today's presentation, we're going to be covering absolutely lots of topics on scarring. Now, you might be a physiotherapist, massage therapist, osteopath, GP, midwife, sports therapist. If you are any of those things and any other professional that treats individuals, then chances are they'll have a scar. And research has shown, and a paper was published about 5 to 10 years ago, that over 10 million people every year have some kind of surgical intervention, but that was 10 years ago. So now the population with people with scars has dramatically increased, especially with the likes, obviously, of aesthetic surgery and with the rise of C-section births. So today we're going to be looking at I'm going to tell you who I am. We're going to be looking at what is a scar specifically, and wound healing and scar formation. And we're going to be looking at the different types of scars, but also for you as clinicians, why do you need to assess a scar? What difference will it make to your treatment and the outcome for your client? We'll also look at registered outcome measures, so you're always continuing to use evidence-based practice. And then I'm going to go through some simple treatment techniques in terms of manual treatment techniques that you might want to practice with your hands, but also with the lymphatouch device as well. We've got those all important before and after photos, so you'll see some of the amazing work that not only scar massage does, but also that combination of scar massage and the lymphatouch device. And then we're going to look at scar rehab plans. So, of course, if you've got any questions, put them in the chat box. Anna will start to help me answer those at the end of the presentation. And of course, then if there's any other questions that you want to ask, please feel free to email Anna or myself, and we'll be happy to get back to you. So next slide, please, Anna. So, who am I? As I've said, my name's Hannah Poulton. I own HLP Therapy Limited, and 22 years ago, I started in physiotherapy. And with a real interest in neuro and musculoskeletal, I became a senior in medicine and neurology, and later the clinical lead for physiotherapy. About 10 years ago, nearly 11 now, I started to have my own children, and unfortunately had to go through multiple operations at the same time. All the operations were successful and everything went well. However, I was left with significant internal and external scarring. And it's interesting, isn't it? And you might hear this in your clinical practice, that people say, oh, I feel better after my surgery, or I'm cancer free, or, I'm really grateful. But I'm not fully living. There is a part of me that still needs work on. And I believe a lot of that is down to the scar. I also believe that if you work in orthopedics, in musculoskeletal, in neurology, then you will have people come through that have had huge surgical operations. And from a physiotherapist point of view, we of course have protocols of getting people up, getting people moving, which is great. That's what we want. But what about the scar? Do we look at the scar? Do we acknowledge that as part of our treatment process? And also, if that scar is tight, if it's pinned in and it's restricting range of movement, or there's numbness or altered sensations, what are we going to do about it? Well, hopefully the rest of this presentation will answer that as well. I own HLP Therapy and the Positive C-section, and I'm the co-founder of Everything Natal. And here we teach postnatal assessments and women's health to professionals as well. Within HLP Therapy, I have an amazing team that work for me, and we provide massage, pregnancy massage and postnatal massage, obviously scar work. We provide acupuncture, women's health internal assessments, and we provide holistic treatment and care for clients. So I'm super proud. We're also based right in the centre of the UK as well, so easy for people to fly into, which they do for treatments, and of course easy to get to. Anna, can I have the next slide, please? So I've been doing acupuncture as well. I've been doing obviously physio, as I've said, for 22 years. But after having my children and my operations, it was then I developed a love of scarring. I did lots of courses, but I really found that I needed more out of what was being offered. So I started to develop courses myself from that physiotherapy perspective, and this is where we are now, teaching, training and clinical work as well. And as I've already said, embarking on my PhD in scarring in February. So I feel very blessed. And of course, as you all know, if you work clinically and you have a family and everything, it's always a bit of a juggle, isn't it? Doing everything all at the same time. So now you know why I do what I do and what we do at HLP Therapy. What does that mean to you? Well, first of all, let's look at why we would even assess a scar. As we've said, does it make any difference to your clinical practice and the outcome for your client? Well, I firmly believe that it does. So a long time ago, 1996, this great quote of what is a scar, and I use it a lot because I really enjoy using it, and I think it's a really good description. So a scar is a macroscopic disturbance of the normal skin structure and function of the skin, formed following the maturation phase of wound healing, and we'll look at that in just a moment. An immature scar may be initially pink hard, raised and itchy before maturing over a 1 to 2 year period. And it changes into a paler, softer, flatter and less itchy lesion. It can be described as atrophic, hypertrophic and keloid, and we'll be looking at those scars in just a moment as well. And this is all very good and a great description of what a scar is. But what happens if you have a client that comes to you that is after the 2 year period and their scar hasn't gone white, flat, softer, paler and less itchy? What are you going to do about it? And we'll talk about that in our treatments in just a moment as well. Can I have the next slide, please, Anna? So you've learned about, what is a scar. Let's have a look at how those scars are forming. And we're going to have a look at wound healing. And we're also going to have a look at fascia and the role it plays within the scar matrix. So with wound healing, you have these great 4 phases of wound healing. But as you know, these phases are never linear, which means they don't follow the same pattern every time. You might have interruptions in wound healing, such as infections, openings, stitches and staples being removed too early and that closure not being formed. You might have too much collagen laid down, resulting in a keloid scar. You might have not enough collagen laid down, so the thin tissues start to stretch within the scars. There's lots of different things that can affect wound healing, such as hydration, nutrition, exercise as well, how mobile the client is, and also where the scar is situated as well. Of course, if you've got a scar that's on your face, your neck, your arms that you see, you're more likely to touch it, engage with it more on a regular basis than something that potentially is covered up. But let's go back to wound healing. So as soon as the skin is cut, then that incision has been made, hemostasis starts. You get this huge, massive surge of blood flow to the area, and the blood vessels around the incision site restrict to obviously stop us bleeding out. And then almost instantly after that, platelets form to come in, which form the scabs that you see on top of your skin, but also start to stick everything together. Now, you then go into that inflammatory phase under the skin as the surface is trying to close. And this is where you get phagocytosis with the production of the phagocyte cells. You get fibrin laydown as well, and this inflammation underneath the skin, where the body's natural healing defense shows that it comes in to clear away anything that shouldn't be there and to preserve and to protect the body. So even though when something is inflamed, we say as professionals, oh, get ice on it, take anti-inflammatories, which is all well and good. But actually inflammation is also crucial as part of the healing process of a wound to try and also clear out all the debris that's in there and make sure that there's no infection. You then get that proliferation stage into the remodeling stage. And if I can just have the next slide as well, Anna, these parts of the wound healing and phase start to overlap within each other and can last up to 2 years. So I always say to clients as they come in and they see me at 6 weeks and they say, have I? Absolutely not. Continue to change, remodel and grow. And of course, hopefully with scar treatment intervention, we can not only speed up the healing process, but help with that function of the scar and the feeling of the scar. So that's the pain and the pulling and the tightness that some scarring can cause. So let's just go back just to that proliferation and remodeling stage. Oh.
Did you lost? Looks like it's working again. It just sounds this. Let's wait for a few moments to get Hannah back.
So sorry about that, folks. Hopefully everyone can hear us, and hopefully we've not lost too many people in the interim. So just to recap, what have we spoken about? We've spoken about what is a scar, and we've started to talk just very briefly about wound healing. And why is it important to know this? Well, it's important to know what stage that your client is at when they come and see you. And we'll talk about contraindications and how and when to treat a scar just later on in this presentation. So we were talking about that proliferation and remodeling stage, and this can take up to 2 years. So of course you're going to see the most amount of changes within your scar tissue within that time. I always see my clients from around 6 weeks, as evidence has shown the risk of getting an infection has decreased around this time. And of course, you're going into that remodeling phase. Now, it's interesting because the collagen laydown of fibers are in wound healing change from this type 3 mishmash formula of collagen to type 1. And what the body's trying to do is very quickly lay down collagen fibers to try and close the wound and obviously protect and preserve life. Now, this is really interesting because we still don't know really why people have keloid scars and hypertrophic scars. Now, They say, obviously, with keloid scars, you're more likely to get it if you have darker skin, if you have a predisposition to keloid scars or a genetic disposition and a family history of keloid scars. But we still don't really know why they keloid in the way they do. And there's something in this formula of laying down collagen fibers to close the wound that actually the scar can become hypertrophic and keloid, but we're still not quite sure why. But good news. Seeing your client early on for scar therapy and scar intervention using the best medical devices can help start to formulate, and what I like to say is almost realign those collagen laydown in a more controlled and beneficial way to the client. So I would never see a client that is still within those super early stages of inflammation and healing. And I most certainly wouldn't see them if they had an infection as well. And can I just have the next slide, please, Anna? So let's talk about the different types of scars, and then we'll talk about infection. So scar therapy, so different types of scars. This is a flat line, atrophic white line scar. And you'll be surprised to know that actually lots of people come to see me in clinic with this kind of scar. And this is why I am not in the aesthetics business. It's not just about making the scar look pretty. It's about what is going on under the surface of the scar, that function and feeling of the scar. And interestingly enough, these kind of scars are one of the worst after they've healed for pulling underneath the skin. Now, next year, I'll have more information for you to possibly tell you why that is. But I also think it's genuinely because these scars look nice, they heal well, the individual does nothing for the scar, and underneath that scar becomes tight. And also coupled with poor hydration levels, possibly poor nutrition, poor exercise, can lead to that tightening, dehydration, and tightening of the tissues under the surface. So don't be fooled if you have somebody that comes in, let's say, that has had, their hip replaced, maybe a mastectomy, maybe, neck or thyroid cancer, and the scar looks perfectly fine. Always ask them, does your scar pull? Does it hurt? Does it affect you in any way? Let's see if we can start to mobilize the tissues to relieve some of that pain, itching, inflammation, pulling, and tightness. Can I have the next slide, please, Anna? Now, hypertrophic scars are by far one of the most popular scars that I treat. And 50% of all scars become hypertrophic. Now, everyone wants that atrophic flat white line scar, but what happens if your scar becomes like this? A hypertrophic scar is when the body lays collagen on top of collagen, but keeps within the scar borders. Now, you could argue that this scar is potentially slightly keloid because it starts off by her right fingernail over on the left-hand side of the screen, and a hypertrophic scar where the body's laid down in the scar borders. And then it slightly becomes wider, becomes flatter again and in the scar borders, and then becomes wider as it reaches the left-hand side of her. So it's interesting that you might not always get the same scar within the same scar. You might have different pockets of scarring. But a classic hypertrophic scar is when the body lays down collagen inside the scar borders and keeps laying collagen on top, on top, on top. So you get this red, raised boot-like appearance of a scar. Now, yes, 50% of all scars become hypertrophic, but also the research has shown still that silicone plus a light compression is best for these kind of scars. And that's because silicone blocks, it's a transdermal water loss barrier, and it blocks the moisture loss from the scar. And of course, adds that protection and pressure over the scar to help reduce that collagen laydown. So still really important. And we'll talk about some products later on. Can I have the next slide, please, Anna? So the next two slides show keloid scarring. And yes, it's another C-section, but can you see on the top picture how actually the scar looks relatively smooth on your left-hand side of the screen, coming over to the middle, becoming hypertrophic, and then a typical keloid scar at the end. Now, keloid scars is when the body lays down collagen on top of collagen and then grows beyond the scar borders. So it's wider than the original incision. And I'm really hoping that over the next 5 years, my PhD starts to look at the reasons why that is as well, and why we do keloid, or come to some kind of realistic conclusion. So yes, so keloids are by far the trickiest scars to treat. They can spread quite easily and they can become super tight and super dry. So what I say for keloid scars is initially good hydration, as in drinking lots of water, and good moisturization on top of the scar. Use a good scar cream or oil. Then get your silicone over there on the scar between that 4 to 6 weeks and get some light compression. So for keloid scars, for C-sections, I say maybe a pair of underwear that gives a little bit of support and compression all the way around the scar. You can use manual techniques on the scar, and we'll talk about that later. And I've started to have really good effects with the lymphatouch device on keloid scarring. But you have to be careful. You have to always watch the tissues change, and you have to start gently and work your way up. May I have the next slide, please, Anna? So this is a keloid scar. As you can see, really good changes within the treatments that we've had. And you can see how originally it's red, it's raised, it's much higher and wider than that initial C-section scar. But what we have done is changed it to the bottom picture over a period of, I think it probably took about 8 to 10 treatments on this, working within the scar, using the lymphatouch and using silicone as well. So don't be worried if somebody has a keloid scar, just always take your time with keloid scars and proceed with caution. Can I have the next slide, please, Anna? So we've learned a little bit about wound healing. We've learned about that formation. We've learned about the different types of scars, atrophic, that flat white scar, a hypertrophic scar, and a keloid scar. We've learned what is a scar, but why is it important to assess a scar? And I know we keep touching on this briefly, but a recent study by Amici et al. Has said a patient's overall satisfaction with wound healing is significantly influenced by the resulting scar. So not only are scars the apparent cosmetic outcome of the surgery or injury, but they also contribute to functional problems. And these include movement restrictions that can affect even the basic of tasks, such as breathing, eating, speaking, coupled with pruritus, which is itchiness, pain, and also psychosocial and psychological concerns. And for me, this study was a breakthrough, because it's what I've been saying for the last 10 plus years, is it's so important that when you have a client or a patient come to you and you know that they've had a recent surgical intervention, or potentially a surgical intervention over the last 10 or 20 years, and they say to you, my scar hurts, it causes pain, it's pulling, it's restricting my range of movement, I can't touch it, I hate the way it looks. Please think back to what you've been learning today, because I do believe it is the missing link with our treatments as professionals looking after individuals. We can do all the functional things and rehab and acupuncture and manipulation and, you know, postural and hydration and nutrition. But let's have a look at the scar. It might be that that scar is just restricting that last 10% of that person's range of movement. Or it might be actually, if you start looking and treating that scar, then actually the person is going to feel slightly better about themselves, more empowered, to then be more on board with the treatment that you're suggesting. So this is why I think scar therapy is imperative for every clinician within their scope of practice to start to incorporate in their treatment plans for the benefit of their clients. Can I have the next slide, please, Anna? So we've learnt about why we should be assessing a scar, but how do we actually use evidence-based practice in the treatment of those scars? Well, standardized scales are useful, and this is a research study by Chu et al. A couple of years ago, and they were talking about the different outcome measures that are appropriate. And it says standardized scales are useful to monitor changes in scar quality over time and to compare scars and the outcome of treatment. It says the evidence base for scar therapy is limited. And this is true because we're not actually assessing what are the best techniques for scars. Scar mobilization is well documented, but the outcome of scar therapy for specific scars is limited because I think people just aren't doing those outcome measures and getting good evidence and data. So it's saying it's limited by the infrequent use of standardized assessment tools across different scar therapies. So what they're saying is, hence, a holistic and valid assessment tool is essential to ensure the progress in wound healing and scar treatment. So in a nutshell, what are we saying? We're saying it's important to assess the scar. It's important to understand about wound healing. It's important to offer that holistic assessment, which we'll talk about in a moment, and to incorporate scar therapy into that assessment and use the best outcome measure. So Anna, can I have the next slide, please? This slide talks about the different outcome measures that not only do I use in clinical practice, but as part of that research paper that we've just spoken about, has rated which scar assessment tools are the best to use. And they talk about the VAS, they talk about the breast and scar Q, and they talk about, I call it the SOAS. Now, you might know already about the visual analog scale, 0 being no pain, 10 being the worst pain imaginable. And of course, you can use that in a scar. So I can say to you in your treatment therapy, okay, you've got a scar. So scale of 0 being it doesn't bother you, 10 being it impacts everything you do. Tell me where you are on that scale. And of course, I'd ask the same question every single time they came in. And you might want to start doing that in treatment. If they say, my scar is really painful, then you could use the visual analog scale. They could say, actually, I hate my scar so much. Okay, so how does it bother you? Use the same words and the same questions and the same outcome every time, so you can start to see how your client is progressing. Now, the breast Q and the scar Q are validated and assessed outcome measures for scars, and they hold a good evidence base of being used for scar assessment. You have to, if you type this into Google, you have to request them from the people that have designed the SCAR scale that are based in America, and then they give you permission and access for the outcome measures used. In the next slide, in just a moment, we'll just have a look at how the SCAR Q, how I use it in clinic, and actually what is included in it. It's really good because it acknowledges the physical and the emotional impact of scarring. So I'd really encourage you to have a look at these outcome measures and see if they'd be beneficial for your clinical practice. The Patient Observer Scar and Assessment Scale, the SOAS, or POSAS, however you want to pronounce it, has been updated. So if you're using that, then I would urge you to have a look at the updated version. And this is a shortened, condensed version of the SCAR Q and uses that same scale of not impacting you very much to 5 impacting you a lot. These 3 have been assessed and been tested and have been shown to be good outcome measures for scars. Within my PhD, not only am I going to be using the VAS and the SCAR Q, I'm also going to be taking photographs with the client's permission, and I have tape measures with colours and charts on them to visually chart the progress of the scars. So we can see on a surface level how the scar's changing, but also how it's changing underneath the skin as well. Can I have the next slide, please, Anna? So this is the SCAR Q, and we will quickly get on because we've got lots to get through and time is ticking on. You'll see on the left-hand side of your screen, you've got the symptom scale, and it says my scar is dry or flaky. 1, not at all. 4, very much. What you do is then obviously ask these questions, circle them, and each number carries a point. You add up all the points, and then the chart next to it, you can see it says sum score. Underneath that, you look at what sum score they have and then find their total, and it's out of 100. And this is a very nice way of looking at how the scar and how they are changing as an individual. You'll see that it goes from symptoms, it goes on appearance. How does your scar look from far away? Does it bother you from far away? And how does it look close up? To that psychosocial impact. I get upset when people see my scar. I feel embarrassed. I feel upset. I dislike my scar. And I really think as clinicians, offering that holistic assessment, we need to make sure that we're identifying the physical needs and addressing them, and those emotional needs as well within your scope of practice. May I have the next slide, please, Anna? So very quickly, this is the patient observer scale and patient assessment and observer scale. And the same again, it doesn't bother me very much or extremely bothers me. And this is another good one to use. It's a lot shorter, as we've said, than the SCAR Q, and it has some evidence behind it to say how effective it is. Next slide, please, Anna. Lovely. As I've said before, photographs and tape measures. These are the tape measures that I use from a company within the UK. Not that we're ever going to take the scar away. We're never going to make it invisible. It's going to be a scar for life, but it will change and it will look shorter and it will change in terms of colouring as well. And of course, it looks like the length of the scar has changed as it's healing. But that's because it starts to blend in within the skin. So all of these are really good. But of course, you would use photographs with the client's consent. We have written documentation that we use to gain client's consent. And of course, you need to comply with your data protection in terms of storing clients' photos. So I use an online notes platform. I take photos, I then put them onto their online notes and then delete them from our phone in the clinic. So it's really, really important that as we're taking documentation or taking photos, we're storing it correctly. But of course, photographs and tape measures are very subjective, aren't they? They only tell half a story. The photo that you can see here, you can see dramatic changes. However, and this was in a couple of treatments, however, you don't know the time that this was taken. Obviously, lighting is different. You don't know how many treatments were, and also you don't know what the real problem was. It could be actually that the scar itself was fine in appearance, but actually it really hurt the client, and that's what we were treating. So if you're going to take photos, never just do this in isolation. Please use a validated outcome measure as well alongside it. Next slide, please, Anna. So we've been talking about very briefly about manual techniques, haven't we? And scar therapy, and I keep talking about it. But actually, what is it? Now we've learned a little bit about wound healing, scar formation, different types of scars, outcome measures, and assessing the scar. When do you actually start the intervention? And also, what does it mean? What does it do? So scar therapy is mechanotransduction, which means it's an external force creating an internal change. And what we mean by that is touching the scar with our hands. Doing this will not only start to fire the receptors of the skin, start to release endorphins of that gentle touch, start to create blood flow within that area, start to generate warmth from the movement of the tissues, but also start with that circulation of that lymphatic drainage underneath the skin and the scar. And what are we doing? We're starting to soften the scars. We're starting to help with that remodeling phase, especially within that 2-year period. We're starting to create space within the tissues. And what this presentation doesn't show, but if you look on my social media channels, you'll see I worked with functional fascia, and we started to look at cadavers, so dead bodies, and looking at how scarring affects underneath the skin. And what are we doing as we're mobilizing it? Well, as we were working and looking at the tissues, you can see how we can create space underneath the surface of the skin with moving, with heat, with medical devices such as the lymphatouch to create that space so that scar can heal, remodel, reform, and start to flatten. We're just distorting the tissues in a controlled way to have a beneficial outcome for the client. So that's what scar therapy is, and we'll go through some manual techniques in just a bit. Now, you would never do scar therapy, so direct scar massage, on somebody that still had their stitches within their scar, staples within their scar, an infection, an opening. hematoma, so a blood clot, or seroma, so fluid-filled sacs under the scar. There's no point working on a scar with all of these. They need to be drained, they need to have antibiotics, they need to wait for the stitches to dissolve or staples to come out before you start touching that scar. Anna, can I have the next slide, please? A definite contraindication is infections in the wound. And if you have pain in the womb, especially after C-section, after delivery, they obviously need to be referred back to the GP, health visitor, or midwife. If the scar is red, swollen, if it's hot to touch, if you've got green, weeping, or clear or yellow discharge from the scar, absolutely don't touch it. If the client with a C-section has got any of the discharge from their body, I'd be highly concerned that they might have an internal infection somewhere behind the scar. I wouldn't be doing scar therapy. And the client themselves, that feeling of malaise, tiredness, fatigue, high temperature, sweaty, and red patches on the skin. Please, as I know you would in your professional capacity, please refer back to a GP, midwife, health visitor, somebody that can assess that scar and then ultimately get the appropriate treatment for them. Anna, can I have the next slide? It's interesting to note as well that if you have a scar that has had an infection, that wound healing phase is taken back a step. So let's say they are 4 weeks post breast cancer surgery and they have an infection on that 4th week and they're on antibiotics for a week. So now they're 5 weeks post mastectomy. What being on antibiotics for a week does is take them back a week in their wound healing. So really important to note that if you have a client come to you and they've been on antibiotics for a period of time, please work out where they will be now in their wound healing journey before you start treatment. I always start scar therapy treatment around that 6 weeks mark, as we've said, as long as there's no stitches, staples, hematoma, seroma, or infections within the wound. And also, ultimately, the client is happy for you to start treatment with them. So let's have a look at the different treatments. We know about scars, about wound healing, about different types of scars, about outcome measures, about infections, and about healing. You've got the client in front of you. You've asked them the questions within your subjective assessment. You now want to look at treatments for the scar. So it's always part of a holistic outcome. Very rarely people come to me just for the scar. It will be a part of a bigger picture, and I'm going to assess that bigger picture as well. Somebody came to me for the scar after shoulder reconstruction, a huge operation, pins, plates, multiple scars, getting great range of movement, which we were working on. But actually, the scar was the last part of the piece to help them get that range of movement. So, of course, I'm going to ask them all the questions about the surgery, about their past medical history, about medication, what they do for a living in terms of, posture, going to be looking at diet, hydration, how do you even sleep? All of these things play a huge part in how that scar is going to recover and heal. I'm then going to do an outcome measure, possibly a VAS and the scar Q. I'm then going to look at their range of movement. So, for example, with the shoulder surgery, not only did I look at shoulder range of movement, neck range of movement, I also looked at breathing patterns as well. Because with scarring, especially around neck, shoulders, and in your abdominal region, you're not going to be taking those deep breaths. You're not going to be getting really good lung volumes. You're going to be breathing shallowly. You're not going to want to cause that pain of the scar after surgery. So it's really important that we start to get some good diaphragmatic breathing, calm the body down, get good nutrition in terms of nutrients, in terms of good quality of air, and all working with the body as well. So really important to look at range of movement and breathing as well. Your scar assessment. People say, so what do I document, Hannah? I say, document exactly what you see. So if the scar is hypertrophic, you're going to say it's a hypertrophic scar. You might want to measure it and say how long it is. You might want to say where it is on the body. You might want to say then how it feels. So it's red, it looks red, raised and tight. And the client reports it's pulling on the left side. You can even say in your range of movement assessment, you can see the scar pulling as you conduct the range of movement. So all of that within your scar assessment. I always think it's imperative that you write it as the scar is and as you see it, so another clinician can pick up your notes and carry on with your treatment within your practice. So manual scar therapy treatment, we're going to come on some techniques in just a moment. And what I love to do with scars, first of all, let's say we're treating a cesarean scar. I would look at diastasis recti, I'd look at the pelvic floor, I'd possibly do an external pelvic floor assessment, internal if indicated. I'd then look at the scar, document what I see, and then manual treatments. I would start sweeping my hands lightly over the scar. You're getting that gentle feedback, that starting to touch that area that client may never have touched before. And I'm going to guarantee that you will be the first person after any surgical intervention to ask the client, can I touch your scar? Can I help, with softening your scar? How does your scar feel? Because we just don't ask those questions about scarring. So yes, as you're working over the scar with your hands, I start with that lovely light sweeping over the scar. And if it's a C-section, like we've said, I'd be sweeping over the tummy, I'd be sweeping over the scar. And this is just to create that nice release of endorphins, to let the client know where my hands are, what they're doing. If the client is feeling numb around the scar at all, this is perfectly normal, especially in those early phases of wound healing. And nerves grow back at a really slow rate, about 1 millimeter every couple of weeks. And of course, you have billions of nerve endings, so you can see how long that takes to get the feeling back. But as we know, as professionals, all of our body is represented on our homunculus, in our brain. And of course, you know that if you knock your elbow or stub your toe, you don't have to look at where you've hit. You know that because that part is registered on the brain and it's telling you that there's an injury. When you have that numbness around the scar, the client can't tell you that deep pressure, how it feels. So it's important that we start lightly, we start engaging with that scar, we start the client sweeping their hands over and touching that scar as well, because all of this together will start creating a better sensation round the scar. So I start off with this nice sweeping. I might go to pinning and pulling. So I use my fingers to work along the scar. I circle over the scar as well and in the opposite direction. And I move the scar up and down like so. All of these techniques are just mobilizing the scar tissue, but in a controlled, gentle, and as clinical evidence suggests, the best way possible for scar tissue mobilization. And then, of course, after I've started to soften the tissues and warm that tissue so they're more pliable and moldable, then I would use the lymphatouch device. And in the next few slides, we're going to actually talk about the lymphatouch device and how that works. And then we're going to talk about rehab plans. Now, Anna, we're just running out of time, so we're going to click to the next one and then probably the next one after that, if that's okay. Oh, actually, can I just show this one first of all? So breathing techniques is great in terms of the lovely deep breath. And then this is the pin and pulling that I was saying. You start off with the breath work, you start off with sweeping of the hands, then you start off with that lovely pinning and pulling across the scar. I say you can use some oil on your fingers or cream. Get something that has a really good moisturizer in it, something aloe vera, vitamin E, omegas 3 and 6, something that's going to nourish and start to help hydrate that scar. And you can see how lightly I'm going. And yes, of course, we've drawn this scar on for the purpose of this, but really important. Go light, start light, look at the tissues and see how they're changing. Can I have the next slide, please, Anna? The next slide, there should be a video at the bottom. We've got circles, which, as the name suggests, we're going to be circling round the scar. And if you can, start off the scar and then start to mobilize over the scar as well. So I would start off around the hips and then start to mobilize the scar. I'd also make sure that as you're circling over the scar, you're trying to keep the scar between your two fingers if you're circling with fingers, or in the middle if you're circling with 3. So not only are you moving the tissues, you're also moving the scar itself. It might be that you start off the scar because the client does not want you to touch the scar. It might be too sensitive and painful. So let's look at circles off the scar first of all, before we start to go on the scar. Also, if you think of surgeries like C-sections and how they cut through 7 layers, they don't go straight down, they go in at an angle. So, of course, you're going to get tightness and adhesions around the scar, like many other scars. So start to work around the scar using these techniques. These zigzag lines or wavy lines, we call them an eraser. We brace above and below the scar, and then start to massage up and down over the scar. Still quite light. What I don't want to see is the tissues going red, raised, sore and inflamed. What we want to do with some good oil on our fingers is mobilize those tissues up and down. You can do it with 1 finger, you can do it with 2, you can do it with 3, you can use your whole hand. But whatever you do, stay with the same technique and get the client to do those same massage techniques at home as well. Next slide for me, Anna. This is another one, so very quickly, we won't watch all of this. This is rolling, it's lifting and mobilizing the tissue with both hands up and down the scar. You'll see lots of people on social media pulling scars, rolling between their fingers, shaking. We don't need to be doing that. There's a time and a place for that, and it's definitely not with your first, second, third treatment. Let's respect the tissues, let's work with the tissues, let's move those tissues as the scar is changing and the client is adapting to what you're doing to them as well. Because I can guarantee if you're the first therapist that said about scar massage, you're going to be the first person to ever touch that scar. Okay, next slide for me, please, Anna. And we'll move on from rolling. So the initial treatment with the lymphatouch device. So we've learned about wound healing, scar massage, contraindications. We've covered loads of aspects of scarring and some manual techniques. To have the lymphatouch device as part of your treatment not only accelerates the treatment in terms of scar healing, it also delivers great feedback to the patients. They can see something working and moving. Now, as I couldn't have a client here with me while I was doing this assessment, I've thought of a different way, and you can maybe see my body there, and we've got a C-section scar on here. And as the video shows that Anna might want to just play again, I start with the cup away from the scar, going across the scar, across the tummy, beg your pardon, like so, before I then start to get towards the scar. Why do we do this? We do this so that the client starts to get used to the lymphatouch device, how that feels, so we know that the pressures are right. And I always start off in the first treatment about 90 milligrams of mercury, so millimeters of mercury, and then work up as the client tolerates. Now, this is also a great outcome measure because, of course, the first time the client comes in and they're on 90, they come back for treatment a couple of weeks later. You might do 1 minute of 90 with the lymphatouch, but then you put it up to 120. They can tolerate that, so you put it up to 150. You gently increase it. And what are we doing with the lymphatouch device? Well, we're lifting those tissues. So you've got your skin, you've got your fascia, you've got your fat, and you've got your scar. And we're lifting that to create space and flow of the lymphatic system under the scar. Also, with the super tight scars, the scars I was treating this morning, a gentleman that has had eyelid surgery under and above, and then a brow lift as well. Lots of scarring within such a small space. I used the lymphatouch around his eyes this morning with dramatic results. I wish I'd taken a photo to show you. But it softened the scar because you have obviously very little fat around your eye and everything had been removed, so it was tight. But what it did was lift the tissues and the scarring to almost create this flow and this softening of the scar tissue above the surface. So super, super important, really good. Can I have a look at the next video, please, Anna? So you start off above the scar like so, and you'll see that on the video. And I'd start here and then go over the scar. Funny enough, I also start with the medium-sized treatment head as well. So not the large one, but the medium-sized one. And this one is great because the client can see it working. You can get a good indication of how they're going to benefit from the treatment and if they like it or not. Starting off with 90, working up. I then go, as the video shows and my diagram here, straight across the scar. Now, what that video doesn't show you is I'm holding one side, so I'm bracing on their hips, and I'm moving the lymphatouch device across the scar like so. Now, direct scar massage, obviously, you know, it's quite invasive for some people, so take your time. Make sure you've got some oil on the skin so the lymphatouch device slides across the top as well. Can I have the next video, please, Anna, the next slide? Just like you do with your hands, and yes, please press play, you can then do a zigzag motion up and down the scar like so. And what you can do, and what I couldn't show you in this photo, is I'm bracing above the scar and then sliding the lymphatouch down, up, and down, up. So you've got some purchase to pull across as you're working on that scar. Now, we're doing this with our hands, working up and down. We're doing it with the lymphatouch. The difference is, of course, with our hands, we're pushing in, and the lymphatouch is bringing out. So a combination of both of them yields dramatic results, because as I'm working in the scar, I'm working over the scar and doing everything that we've said, the lymphatouch then creates that space to allow us to work even more. So we go over the scar, first of all, over the tummy. If we're doing a C-section, we then go over the C-section scar. We then can do circles with the lymphatouch. We can do zigzag formation with the lymphatouch, just like you would with your hands. So it's a great adjunct. I've also found that clients enjoy using it. I never have any problems with it, and I'm sure you are the same as well. Can I have the next slide, please, Anna? So I just show here just with an atrophic scar, so a white flat scar. I use this small treatment head that you can see here. Now, not only do I run it over the scar, on the side of the scar for those hypertrophic scars, so where you've got that raised scar, I work with the lymphatouch head in the side of the scar, slowly trying to bring it out. And as you can see here, popping the device onto the skin and then lifting the tissues to create even more space, that more lymphatic drainage underneath the surface of the skin. And I do this as well on that side of the hypertrophic scar. Now, keloid scars, like we've said, be super, super careful. Use your device. I normally use this at 350, but with a keloid scar, I'd reduce it to about 280, depending on the scar. And then I would slowly start to work by the side of the scar with the lymphatouch device, smoothing and flattening out that scar and trying to soften those tight tissues. I've used this a lot with burns and high-level burns with great results as well. Can I have the next slide, please, Anna? So very, very quickly, and we're literally going to whip through this because time is against us. You can see the different changes with the lymphatouch device and manual techniques that I've been using, from the top of your screen when the client first came in to the bottom of the screen. Can I have the next slide for me, Anna? Thank you. There are obviously a high load of C-sections first of all, but you can see the difference that the lymphatouch and manual therapy makes to these kind of scars. And the next slide for me, Anna. And that's the keloid scar that we showed before, but just from a different angle on the other side of the screen, you can see how flat it is in comparison to when it was first started. And the next slide for me, please. Thank you. Another C-section, how it changes. The redness comes out. It's not so raised. It's not so aggressive. And you can see, you know, it's a few months after as well. So really quick healing. And again for me, Anna, please. This is by far my best C-section recovery that we've had in terms of skin texture, lots of trauma, lots of emotional attachment to this C-section, but the differences in change in texture and lay down, and this took about 6 or 7 treatments to get that done. And the next slide for me, Anna. This is by far one of the best arm scarring that I had. Lady that had chemo into her veins after her mastectomy, her lumpectomy, sorry, and of course those veins shut down, so tightening. But see how the muscle wastage is in the top photo. Look at how, you know, how tight everything is, restrictive. And then look at the bottom one, and this took only about 3 or 4 treatments. It was actually really quick, and we used the lymphatouch device on this as well as a combination of manual techniques. Next slide for me, please, Anna. And this was by far one of the best mastectomy improvements. Look at the quality of the skin, the texture, the smoothness of the scar. The scar actually looks bigger in the second photo because of actually how flat it is and how it's spread out, but that softening of the skin as well. And the next slide for me, please, Anna. Now, let's have a quick look at a scar rehab plan in the last few minutes. So we've had a very whistle-stop tour. Normally I do this in a whole day, so you can see how quick we've had to be today. We've learned a lot about, scar rehab and management techniques and holistic assessments, outcome measures, scar therapy, contraindications, wound healing. But maybe you've done all of that. So what is a good scar rehab? To basically connect everything together. So frequency of treatment, if I've got a brand new client, they come into me at 6 weeks, I want to see them once every 2 weeks for the first possibly 3 sessions or so. And then as the scar is maturing and changing, I'm going to start to spread that out to possibly once then every 3 weeks, 4 weeks, going up to once every 6 weeks, and then finally them not needing to see us anymore. I use heat, and I've got a heat device which is great to open those tissues and to pump some heat through it and soften and blood flow, really important. And of course, we do scar massage work as well, and I teach the clients how they do scar massage too. If they've got a scar on their abdomen, we've got to get core engagement. We've got to get those muscles activated underneath the scar, transverse abdominis, rectus abdominis. We've got to get those muscles firing, moving, helping pump everything around as well. Your scar massage is nothing without the client having good hydration. We need those tissues to be sliding underneath the surface. Good hydration and good nutrition, plenty of protein and the building blocks of cellular recovery. And of course, if they've got those stresses, those emotional concerns, I refer to the counsellor that works as part of our team to help identify that, because that is not within my scope of practice. And of course, it's important to acknowledge that and listen, and I can help, but I'm not a trained counsellor, so anything else needs to be seen by a professional. And of course, for my postnatal clients especially, pelvic floor work, super important, so work within your scope of practice. And then desensitization work. I might use a soft face cloth over a scar, a clean makeup brush, cotton wool, something that's soft that can start to create good sensations within the scar rather than it being fiery and numb and it being uncomfortable for the client. So really, really important. And I tell my clients to do their scar massage at least 10 minutes a day, 5 minutes in the morning, 5 minutes at night, 10 minutes at night if they want to. If they want to do 15 minutes, great. But always make sure that we're not inflaming and making that scar go red. Next slide for me, please, Anna. We're coming to the final part of our questions, and if you just flick to the next slide as well, Anna, for me. We just have, if you want the course, unfortunately that was the wrong picture for my online scars course. The price is actually $349, so if you want it for $199, you can use the code HLP99 course, and you can get it for $199. My online program has over 21 videos of all different scars that you can then know how to treat. And I speak to lots of different suppliers about medical devices as well. So really good. And you have access to all the outcome measures and everything else as well. And if you want to follow me on any of my social media, I have lots of social media out there, all free. And if you want to join the course, it would be amazing to have you on board. So thank you. Anna, shall we answer some questions?
Yeah, thank you, Hannah. It was like amazing 1 hour filled with knowledge that you have for scars. There's one question about the the SCAR-Q and the PSOSAS outcome measurements, and are they available for free for clinicians?
Yes, they are. If you go onto, so if you type into Google SCAR-Q or the SOAS, what they will come up with, the SCAR-Q will come up with a link to two researchers in the States who own the rights for that. You have to then fill out a form. As long as you're not using it for research purposes, it's free. If you're using it as part of research, then you have to ask a whole load of other questions as well. But for a clinician, it's free to use. So yes, so please use them. And the same with the SOAS as well. You can just download it from the internet and use it in clinic, and it comes with guidelines as well. And yes, Lena says, what kind of results can there be with older scars? Well, Lena, that's a great question, because I used to say, oh, I wouldn't treat a scar over 10 or 15 years old. By then, it's matured, X, Y, and Z. I'm treating a 27-year-old breast scar with the lymphatouch device and manual techniques with phenomenal results. And 2 weeks ago, a guy came in that had his appendix out as a child. So, 4 or 5 years old. He's now in his 40s and has had some recent surgery. But this old scar is causing loads of problems now. And after 2 sessions, he's 99% pain-free. And he's just left a review, and you can look at it on Google. So yes, he had another operation a year ago, and that's triggered all this pain off. Just amazing results. So in answer to your question, Lena, I don't think there's a cut-off time. I just say, when clients say, can you help me? I just say, let's give it a go. If you feel nothing within the first 1 or 2 sessions, then we're not making a difference. But if you are, let's keep going. Just don't make any promises. That's what I always say. Don't make any promises.
Yeah, and one of the I have one question, sorry, that I know that it's question asked a lot. So how long are you working directly on the scar? Obviously, it depends on how old is the scar, but usually manual techniques and lymphatouch techniques. How long are you staying on top of the scar?
Yeah, so all my assessments are an hour, so 60 minutes in length. And my first assessment with the client obviously has their subjective, objective, yes, as well. So I probably do 20 minutes on the scar. And that's, of course, checking everything, diastasis and pelvic floor as well. Then when they come in for follow-up treatments, I have them in for an hour again, and I probably treat them, I'd say, for a good 35, 40 minutes of scar therapy. And that's, starting with your hands, your light touch, then starting with, your manual techniques, then starting with the lymphatouch, then going back to manual techniques, then doing maybe some exercises, scar rehab, finishing off then with more manual techniques and finishing it like that. So probably around 40 minutes. Yes, 30 to 40 minutes. You have to be, like I keep saying, super careful that you'll have some scars, especially if they've got really fair skin, auburn hair can have, or if they're really highly allergic to things or have many intolerances, that actually the scar will flare up very quickly. And it's super important that you take your time and don't be worried saying, okay, I've done 10 minutes and actually this looks really sore now. What I'm going to do is do something else, and we might come back to that scar, or I need to get you in, for a shorter treatment next time. and do that. You don't want to send the client home in so much pain and their scar so sore that they're just not going to come back and see you. So yes. Does that answer your question, Anna?
Yes, thank you.
Yes.
There was a couple more just came. Do you use silicone daily with patient for a set time or 24 hours until the next appointment?
Yes. So what I do is I sell silicone packs to clients, and I've written out a whole step-by-step instruction on how to use those packs as well. Silicone can be used for up to 23 hours a day. So what I say is build up the time wearing it, 2 hours the first day, 3 hours the next, 4 hours the next, and so on. And then wear it all day, take it off at night, do your scar massage like you've been shown in clinic, dry the scar, replace the silicone and sleep in it. So only suitable for those hypertrophic and keloid scars. That's a biggie because they need the silicone needs something to press against. So really important. But yes, I use it a lot. As we've said, 50% of all scars become hypertrophic. So you're going to see a lot of people with those red ray scars, and silicone still is the gold standard for helping with those. So yes.
And maybe the last questions, if none else have any questions regarding on scar therapy, but what's the pressure values that they're using with the medium size cup or the 60 millimeter cup? So you started with 90 millimeters of mercury and then build up.
Yes, I do. And it's very difficult to always say this is the protocol you have to use because everyone's different, aren't they? What they can tolerate, how the tissues change, so important. But the medium head, I start off at 90, then we'll probably go to 120, then go to 150, then possibly go up to 200. The first ever treatment, I start at 90. I might do it for 5 or 10 minutes round the scar and then go over the scar with it to see how they feel. And if they say, oh, that's great, Hannah, I can hardly feel it, then I'll raise it up to 120 and lightly go over it as well. I find I get better outcomes gently increasing it and working with the tissues. So yes, but the small one that you saw in the videos of me lifting and lowering the skin, just fantastic in terms of creating that space. And I normally use 350 on these, and with the newer devices, obviously 400s. So yes, really good.
Yeah, and it's important to remember that the different sizes of the cup, the pressure feels different. So that is why you are using more pressure for the smallest cup than with the larger ones. But thank you.
True.
Yeah.
I don't use 50 on these ones,
yeah.
no.
Yeah, that is true. And if anyone have any questions later on, please contact us directly on Hannah or follow her in Instagram and YouTube and any other channel that Hannah is in to get to see those amazing results that you are having on a daily basis. And
Yes.
I believe that everybody here learned a lot of new things about scar therapy and are better in scars after this session.
Yes.
Thank you, Hannah.
Thank you so much for having me, Anna. Thank you. It's been a pleasure. And thank you, everyone, for listening. And have a lovely Christmas.
Thank you. You too.
Take care. Bye-bye.
Take care. Bye.